My name is John Passy. I'm a haematologist from Barts and the London School of Medicine and Dentistry in the United Kingdom. I'm going to talk to you today about gene therapy for haemophilia A and the transfer of the factor VIII gene. And I'm going to cover a number of studies that we have data on currently. Haemophilia currently has a number of treatment options. This slide outlines essentially the history of treatment for haemophilia, from pre-replacement therapy to the standard that forms the backbone of what we do today with replacement therapies, through to what we're looking to introduce now in terms of bispecific antibodies and a new generation of alternative non-factor replacement therapies that are in clinical trials. But we also have gene therapy. Gene therapy has been the holy grail for haemophilia treatment for many years. Gene therapy, though, for haemophilia is essentially addition of a normal factor VIII or factor IX gene. It is not, to date, gene editing. Cellular gene therapy is something we may see in the very near future, but I'm going to be focusing on the data that we have to date on gene addition approaches for gene therapy for haemophilia. There are many different approaches to these treatments. Substitution and replacement therapies have pros and cons, as does gene therapy, which of course is still at an investigational stage at the moment. If we look at gene therapy, the things that set it aside are the fact that it is a once and done therapy. Once you've given it, hopefully you're not going to need to give it again, but equally once you've given it, you probably can't redose, and once you've given it, you can't top up either. It does give us a steady state of hemostasis, and it may produce what we could call curative levels, even if not normal. What do we mean by curative levels there? Well, we mean potentially people being allowed to lead pretty normal lives without any replacement therapy, and this gives us the opportunity for quite significant cost savings. On the other side, substitution and rebalancing therapies reduce the burden. They don't provide necessarily quite the same steady state hemostasis, but they do provide it in some form. And they are applicable to adult and pediatric populations. Gene therapy at the moment is essentially something that is restricted to adults because of a number of scientific limitations on applying current technologies of gene therapy to children. We can also use replacement and substitution therapies in inhibitor and non-inhibitor patients. But these approaches don't create a curative normal level in essence. There may be other associated risks such as thrombosis, issues in relation to measuring clotting activity and having to manage peak bleeding risk events. For gene therapy, of course, there are also going to be cons. One of the major cons is eligibility. As I've already mentioned, gene therapy is only at the moment for adults. It's not applicable to children. Those who have pre-existing immunity to the vectors that are used, which is today essentially AAV, would also not be eligible. There are also going to be a whole list and raft of known and unknown risks because this is a completely new paradigm shifting approach to medicine. Are we going to see immunological changes, cellular stress, or integration risk because we're actually moving genes? These are some of the things that we question and we don't know the answers to. And of course, there may be unknown things that we find in due course with the follow-up of our patients. Durability of gene therapy is absolutely key. One of the things that we want is to be able to treat patients, to know that it's going to last and to know how long it's going to last. Until we have the data, the durability will remain a very open question. And gene therapy is something that everybody recognizes is going to come with very high costs. The technology that is most popular at the moment is adeno-associated virus-mediated liver-directed gene therapy. Here, essentially, a small adeno-associated virus, which is replication incompetent, has its genetic material replaced with the therapeutic gene of interest, either factor VIII or factor IX. The various serotypes of AAV that are used are such that they target the liver and are hepatotropic and so can transduce liver cells. Following intravenous injection, the virus will therefore transduce liver cells, release its genes into the cell and the host genome, and from that express proteins which are going to be secreted and produce our factor VIII and factor IX that we're going to see in the circulation. So against that background, I'm going to talk about a range of haemophilia A programs for gene therapy that are listed on this slide. And I'm going to go through the latest data that we have on these programs as of August 2020. The program that is furthest ahead at the moment, and we have the most data, uses AAV5 with a factor VIII SQ expression cassette. This is the Biomari BMN270 program. This slide shows a schematic of the AAV expression cassette. As we can see, we have the B domain deleted, factor VIII SQ encapsulated within 2 inverted terminal repeats with an ApoE alpha-1 antitrypsin modifier promoter. The gene has been codon optimized to get best expression. The study to date has presented data on 15 patients who were treated in 4 cohorts. 13 of these patients treated in the 2 highest dose cohorts have had expression levels that can be measured and followed for up to now 4 years. The patients in this trial largely came into the program having been on prophylaxis, but a number of them who were on prophylaxis still had significant annualized bleed rates. And as we can see from the right-hand panel, prophylactic therapy, the 14 patients came in with an annualized bleed rate of around 6.5. This is the key data from this program, which now follows patients out over 3 to 4 years. This is the data that was published in the New England Journal of Medicine at the beginning of 2020, which shows the data at 3 years. This is the highest dose cohort that was treated, 6E13. The different coloured panels represent different ways of measuring factor VIII. Blue for the chromogenic assay and amber for the one-stage assay. As we can see, over the first year, the levels go up, and then there is a shallow decline over years 2 to 3 in the patients here in both assays. The reason that we've shown both assays here is that there is a discrepancy for all gene therapy programs between factor VIII measured in the chromogenic assay and the one-stage assay. The chromogenic assay essentially shows a level that is about 70% lower than the one-stage assay. So whenever one is looking at the data for these programs, we need to be very careful to ensure that we know which assay is being used so that we can compare program to program. What we've seen in this program with BMN270 is that when the patients have been treated and they've clearly expressed factor VIII, they have had a dramatic reduction in treated bleeds. These 2 panels here represent the higher dose cohort 6E13 on the left and the lower dose cohort 4E13 on the right. And as we can see, the 6E13 cohort has been followed at 4 years and the 4E13 cohort out to 3 years. We can see in both panels that pre-infusion there was a significant number of bleeds that required treatment. We can also see that there has been a huge reduction in treated bleed requirement after the infusions have been given in both doses, both dose groups. So in essence, we're seeing a 90% or more greater reduction in bleeding that requires treatment. Those patients that have bled in both these cohorts tend to be those at the lowest levels of expression. And we can see from the lower panels here that the majority of patients in these programs have remained bleed-free, and all the patients, all 13, remain off prophylaxis at the end of year 4 or year 3, depending on which dose they were being treated with. Given that their treatment is there to protect them from bleeding or to treat bleeding, it is not surprising that if the patients have a dramatic reduction in actual bleeding events, that their treatment requirement will go down significantly as well. And here we see annualized factor VIII usage in the 2 cohorts reduced by 96% after infusion. This is, as I say, not really a huge surprise, but it is potentially one of the most important observations that we see with all gene therapy programs. When factor VIII is expressed, the treatment required collapses dramatically. This slide shows the chromogenic assay results for both the 6E and 4E13 cohorts. As I said previously, it's important to bear in mind which assay we are looking at when we look at these types of results. Amber represents the 4E13 cohort and green represents the 6E13 cohort. The 6E13 have been now followed out 4 years, and we can see that they have a median expression of 24% at 4 years with a mean of 16, and the lower dose 4E13 cohort a mean of 8 and a median of 10 units per deciliter. What we see here is after the first year, a shallow decline in expression. We can see this perhaps more clearly in this scatter diagram here, which shows all the results taken for all the patients. Black is 4E13 and amber is 6E13. And we can see that a smooth line taken through all these results shows that there is probably a slow, shallow decline through the follow-up period. On this slide, we have the individual data for the 13 patients in the 2 cohorts. We have 3 panels, the annualized factor VIII usage on the left, the current factor VIII at the end of the 3 or 4 year period in the middle, and the annualized treated bleed rate in the panel on the right. If we look at the annualized factor VIII usage and the annualized treated bleed rate, we will see 2 graph lines around the center point. The graphs to the left represent treatment in the year prior to gene therapy, and all the data to the right of the central line represent annualized results following gene therapy. The current range of factor VIII is represented by a range of symbols, which are shown in the graph below. What we can see very clearly here is that the factor VIII usage for every individual has rapidly and dramatically declined, as have the treated bleed rates. We can also see that the treatment that has been required and the bleeds that have occurred are largely restricted to a couple of individuals, and these are those who happen to have the lowest levels chronically expressed, and typically the bleeding has occurred into target joints. In terms of safety and tolerability, this program has demonstrated that there are very few adverse events, and certainly none that have developed over the longer period. The commonest adverse event, which is common to many gene therapy programs, is raised ALT elevations, but these have not led to any long-lasting clinical sequelae. And as I've mentioned, importantly, over the follow-up period of up to 4 years, there have been no new drug-related events. There have been serious adverse events in relation to patients being admitted to hospital, but these have been unrelated to gene therapy and largely relate to elective surgery. Whenever we think about haemophilia A gene therapy, we're always concerned about patients developing factor VIII inhibitors, and with this program, there have been no inhibitors developed and there have been no thrombotic events. We also are aware that many of these programs use corticosteroids, and so long-term clinical sequelae for corticosteroid use is also important to bear in mind, and there have been no issues here that we've seen with this program. So let's think of a case scenario. Let's consider a young man who's got an interest in having gene therapy. He's 23, he's got severe haemophilia, he's been on good prophylaxis most of his life and is on a good treatment now, and for several years has had excellent bleed control. He's got no target joints and no arthropathy or chronic pain, and he's got a busy life looking forward to starting an engineering job, having just finished college. He's very excited about the prospect of gene therapy and the prospect of being able to stop prophylaxis, expand his life and do sports that he enjoys more, and not to have to think about his haemophilia anymore at all. So the question that we have essentially, is gene therapy right for him now, or should he wait for something better? Does this really offer a possibility for him to be normal, or will it be the only treatment he'll ever need? Well, thinking about this, when we talk to our patients, we need to consider a number of issues. First of all, we might look at all the data that comes through, and we might want to consider what the expected outcomes might be, what that might mean in terms of plasma level of factor VIII or factor IX, based on what's been seen. What's the durability going to be, and how can we determine that from the early phase trials? And what's likely to be the expected impact for his bleeding and factor utilization? So looking at this in reverse, we could say his factor utilization and bleeding profile is probably going to change dramatically if he expresses factor VIII. We've seen from the previous data that this is something that really does get reduced hugely. And we'll see from later data in this module how this is true across all programs. In terms of durability, well, we know what we've got for 4 years now for one particular program, but for other programs, this is going to be something that only time will tell. Whenever we talk about levels, this is something that people are going to be really keen on. What can they actually expect? We must bear in mind, though, that when we look at the data that is presented on all gene therapy programs, we often have medians and means presented to us. The median, of course, means that 50% of people are going to do better than that, and 50% of people are not going to do as well. We need to focus on those 50% who are not necessarily going to meet that median. Are they going to be happy with the lowest levels that are presented in the trial data? Is that going to make a significant difference for them? Is it something they're going to be happy with? Are they going to be disappointed if they get less than the median? This is something that's really important because we don't want patients to be regretting having gene therapy because it doesn't meet their expectations. Coming back to the bleed risk and factor utilization, what we can see from the programs to date is that if we do express, even at what we might regard as lower levels, it does make a huge impact on patients' lives and reduce their factor use. We must also talk at great length about the challenges of gene therapy for the future. If it doesn't last forever, can we redose? Well, today we probably can't because of the presence of neutralizing antibodies, but considerable work is being dedicated to try and look at novel strategies to allow and facilitate redosing. I don't feel that this is necessarily a real possibility within the next 5 to 10 years, but as mentioned, a huge amount of work is being focused on that, maybe using alternative serotypes, maybe plasmapheresis, but more probably non-viral approaches. Now, of course, this gene therapy that we've been talking about so far with BMN270 isn't the only gene therapy that's out there. There are other programs that are actively researching this area and being looked at in clinical trial. This slide refers to SB525, which is an AAV6-based gene therapy, again with a B-domain deleted factor VIII construct. The inclusion and exclusion criteria for this trial are very similar to those for BMN270 in that neutralizing activity to the host capsid, in this case AAV6, is an exclusion, as would be a history of liver dysfunction or inhibitors. The study status of this program is moving on, and we are now seeing data being presented from patients in cohort 4 who are at the highest dose. As with all the programs, these studies have moved through a series of dosing escalations to find out what the most appropriate and best revealed dose may be. This data was first presented back in 2019 at the ISTH meeting in Melbourne, with the first patients here being presented. And as we can see, at the lower doses, there was relatively limited expression of factor VIII, but at the higher dose that was used, 3E13, we can see quite interesting and good early expression of factor VIII. At the WFH meeting recently, we saw more data on the higher dose cohort at 3E13, and this slide represents 5 patients in that program. we can see that 2 of them are expressing continuously up to 64 weeks at really good levels. The remaining 3 patients have somewhat lower levels and had a peak that declined a little, but nonetheless, all of them are expressing at levels that will dramatically change bleeding pattern and treatment requirement, and all essentially above 20%. If we look here at the highest dose cohort, we similarly see, as we had seen previously with BMN270, that there are ALT elevations, and the patients do require steroids to be administered and tapered over a number of weeks. Steroid use is there to prevent factor VIII expression being reduced, and we can see that there may be some impact on factor VIII expression by the ALT rises. But overall, this is quite a common observation for gene therapy programs in that ALT rises are seen. What are the conclusions that we have to date with this particular program? Well, we have follow-up ranging up to 65 weeks, with the program being well tolerated, much as other gene therapy programs, and sustained factor VIII levels. Patients are not requiring treatment because they're not bleeding, and there are few adverse events. This trial associated 1 SAE during vector infusion, but there have been no additional SAEs that have been seen. Clearly, all these cohorts are going to be followed over longer periods, and as with all programs, we're looking very closely for safety signals, and this is another program that has not generated any safety concerns. So this early data, which is very encouraging for this particular program, which shows similar data to BMN270 in one respect, is looking forward to going through into the phase 3 study. Another program that we've heard about for haemophilia A is the program from Spark 8011. This slide outlines the 14 patients that have currently been presented in different dose cohorts, and again the eligibility criteria, which are very similar to the other programs that are out there. Essentially adults who do not have seropositivity to the underlying serotype of the AAV that is used, and again without significant evidence of liver disease. This slide shows the baseline data of the 14 patients that have been included in this program, and as we can see, they've all got negative pre-vector neutralizing antibody levels. A number of them have quite significant joint arthropathy, and there is a history of hepatitis C in a number of the patients. On the far right-hand panel, we see that a number of patients had to receive steroids as part of the program, and I will go into some of that detail in later slides. This slide presents the safety data for the 14 patients in this program. As we can see, the patients have now been followed for a mean of over 2 years, and in some cases up to 40 months. No factor VIII inhibitors have developed, which is clearly an important observation for all factor VIII programs. Adverse events follow a similar pattern to other programs in that there are occasional acute infusion reactions, but the most common adverse event is abnormal ALTs and liver function changes. The mechanism of the liver function abnormalities differs potentially between different programs. With SPK 8001, this is thought potentially to be due to a CTL response to transduced hepatocytes. Steroids are therefore critical to its management. One of the patients that is described here had a grade 2 transaminitis, which resulted in elective hospitalization for intravenous steroid administration, and the fact that he was admitted qualified it as an SAE. However, the event resolved and there have been no longer-term steroid-related issues. This slide presents important data on vector clearance. What we can see is that there is clearance of the vector from a number of bodily fluids that have been analysed by 6 weeks onwards. This slide looks at the efficacy in terms of bleed events for the patients in this program. Much as we've seen with other programs, factor VIII being expressed translates into dramatically reduced bleeding, both spontaneous and traumatic. And here we see a 91% reduction in bleed rate. As previously, this is going to translate into a significant reduction in factor VIII infusions. And as we've seen from the other data that I've spoken about, factor VIII infusions required prior to treatment are significantly more than that after treatment. And here we see a 96% reduction in factor consumption. This slide shows the factor VIII data for the patients in the first part of the program and shows the follow-up for around 3 years in the patients that have been followed for the longest period. The data shows smooth lines drawn through the individual data. I think it would be important to look at this data at an individual level to see how the expression is behaving and the durability of the response. In the next 3 slides, we're going to look at some of the patients who were treated in the highest dose cohort in this program. This slide represents 2 of the patients who did not receive steroids and showed stable expression of factor VIII out to 106 weeks. This slide talks about 5 patients who received steroids in response to suspected capsid immune response. Unfortunately, 2 of the patients lost expression of factor VIII and had to return to factor VIII or emicizumab prophylaxis. 3 of the participants were able to maintain factor VIII expression despite having raised ALT levels in response to therapeutic use of steroids. This also begs the question about whether, if we are going to have issues with ALT rises and needing steroids and the potential loss of factor VIII expression, we should be giving steroids up front. And this group looked at prophylactic steroids. And here on this slide, we see the results of 2 of the later participants who were treated with prophylactic steroids. If we take these 3 slides together, we can see that a number of patients do require steroids. A number of patients have different responses, and there are different rates of ALT rises and different impacts of the immune response to the capsid. In essence, these are important questions which, across all gene therapy programs, we don't have a full handle on at the moment. That is, the complete impact of ALT rises, the impact and use of reactive or prophylactic steroids, and together how we might develop the best approach to addressing these issues. These are clearly issues for all gene therapy programs, but highlighted very nicely in this particular set of data. This slide presents the summary of the data that we can see from the SPARK 8011 program. A range of doses have been tested and patients have now been followed out to over 3 years, and there appears to be a durable expression in these patients. With that comes a significant reduction in bleeding, and with that, a significant and substantial reduction in the requirement for treatment. Unfortunately, 2 of the 9 participants lost expression and had to return to prophylaxis, and this may represent the CTL response. As mentioned previously, these are key issues that we need to understand across all gene therapy programs. The next program that we're going to look at briefly is the A259023 program, which uses an AAV HU37 serotype. This is a serotype that was chosen specifically for its liver tropism and for a hopefully lower rate of pre-existing seropositivity in the population. This program has again been tested in a phase 1/2 study at a range of doses in a dose escalation program. As with all phase 1/2 studies, this is a study that is going to be focused on safety and tolerability as well as factor VIII activity. The study population are very similar to those that we have seen in previous programs that I've described in this module. The initial data has shown that we can get expression of factor VIII, albeit at relatively low levels, in the initial doses. Interestingly, we see one patient here that appears to be expressing very well. The important feature here is going to be following patients out and stepping up through the dose expression program. This slide represents data from 2 patients in cohort 3. 3 different aspects are presented on this slide: ALT in lime green, factor VIII chromogenic levels in red, and corticosteroid dose in black. What we can see here for these patients is that they did get ALT rises, which required corticosteroid use to manage them. We can also see that they continued to express factor VIII throughout. There did appear to be, though, in both these patients, a second recrudescence of ALT rises, which required corticosteroid increase. Nonetheless, the patients did very well in terms of low bleeding and low treatment requirement through this period, and there were no other adverse events. So what we're seeing here is again the same pattern of ALT rises that we see with AAV gene therapies. The last program I'm going to talk about briefly is some data that has come out of UCL St Jude. This data is based on a slightly different factor VIII expression cassette basis. Rather than using a simple B domain deleted factor VIII expression cassette, a short peptide segment, which is known as V3, is inserted in the place of the SQ linker. What can be seen on the right-hand panel is that the V3 cassette expresses factor VIII at much higher levels than a standard B domain deleted factor VIII, which is shown in the solid grey on the right-hand panel as the left-hand bar. The principle here is that this modified V3 expression cassette may demonstrate significantly higher levels of factor VIII, or equally, a lower level of virus may need to be administered to achieve the same end. This slide shows the conclusions from the initial data that was presented using a V3 variant encapsulated in an AAV8 serotype that was presented at ASH in 2018. This clearly is very early data from a limited number of 4 patients treated at 2 separate doses. Those patients that did express greater than 10% clearly had a very significant impact on reducing bleeding and reducing factor VIII usage. The important point that I want to bring out, though, from this slide is the common feature again of transaminitis and ALT rises that are seen in the different program. This is something that clearly has been a theme running through all these programs, that the main issue that we need to try and address for gene therapy, aside durability and expression and understanding variability, is how to manage and address the early transaminitis that we see. In summary, we have a number of gene therapy programs that are in clinical trial, ranging from phase 1-2 through to phase 3. The longest durability that we have is data up to 4 years from the BMN 270 program. However, all the programs are presenting positive results, expressing factor VIII at levels that dramatically impact bleeding and dramatically reduce treatment requirement. However, there are common themes that run through these programs. The first is that they all broadly have favorable safety profiles. There is considerable variability that we see across the levels, and if we look back at the data that we have reviewed in this module, we can see that there is considerable variability between the lowest and highest expressing patients. There is a significant issue with transaminitis across all programs. There is potential variable causation of this which we don't fully understand at the moment. And with that goes differences in approaches to management. Should we be using steroids in a reactive manner for those patients that do have elevated transaminases, or should we be using it prophylactically? This is something that remains an open question and is far from resolved at the moment. There is uncertain durability with gene therapy, and only time, unfortunately, will answer that for us properly. However, one thing that we can be sure about is that we do see effective control of bleeding and significant reduction in treatment requirement across all these programs. Patients who have been treated with gene therapy who express factor VIII all do very well from a clinical perspective. There is great optimism in the field for the phase III data programs that are underway, and indeed the field in general, and we look forward to seeing more data as it comes through. Every new bit of data provides a new insight into gene therapy for haemophilia A. As I've mentioned, we have a lot of questions and we have a number of theories that we can establish to try and answer these questions. That is why every new piece of data adds another piece to that jigsaw so that we get a final picture of how best gene therapy can be developed and how we can optimally manage our patients to achieve the best ends. Thank you for listening.